So good morning, everyone. My name is John. I'm from Ireland. Speaking of titles, I did want to call this my first echo, but I thought it wasn't detailed enough, so apologies for the spoiler in the title. This was a 48-year-old gentleman who was brought into our institution by ambulance after a high-velocity road traffic accident. As you can see, he had multiple injuries, including pulmonary contusions, long bone fractures, and a complex pelvic fracture, as well as traumatic pneumothoraces. So he was brought to theatre and stabilised, then onto the high dependency unit to await complex pelvic surgery. But over the next few days, he started getting sicker. His liver was going off, his kidneys were going off. He was starting to develop signs of heart failure, but managing it reasonably well until, as always seems to be the case, overnight on a Friday night, he got really sick. And when I was asked to see him on my first ever morning as a cardiology registrar on call, he was showing signs of pericardial tamponade. So here it is, my first echo. For those of you who don't look at these, this is fluid here, pericardial fluid, which in this context is a bad thing. And while it wasn't absolutely typical of tamponade by the echo parameters, a quick call to the on-call interventionist, we agreed that it was safest to figure this out in the cath lab. And so we jumped in the back of an ambulance, being in a district hospital, holding manual traction on the leg in one hand and clutching some phenylephrine mini jets in the other. And went the 10 minutes down the road to our local cath lab. And you can see when we got there, this gentleman was very sick. A very rushed right heart cath showed very elevated right-sided pressures and a huge cardiac output. And partly because we didn't know what was going on, we proceeded to drain actually over 1.5 litres of pericardial fluid. You can see we did a reasonable job of getting rid of the pericardial fluid, but there's still some big pleural effusions. And I think it's safe to say that at this point, this patient was very complex and the differential was broad. So we brought him to see our intensivists and asked just about every smart person in the hospital we could find to have a look at him. But despite our best efforts, he continued to get sicker and sicker. His kidneys were deteriorating to the point he needed dialysis. His liver had gone off. He had essentially no platelets left. His INR was over 2, and he had this intractable fluid overload. Here's some echo pictures from the time. So for those of you who don't look at this, the right heart is actually on the left here. And that should be, the right heart chambers should generally be smaller, but they're not here, which is very abnormal. And you can see in the bottom pictures, it's very turbulent color jet coming backwards through the tricuspid valve, which was initially interpreted as severe tricuspid regurgitation, but just didn't quite look right. So we proceeded to transesophageal echo, which gave us our diagnosis because there's a little tear right at the tiny point where the left ventricle meets the right atrium in the septum, consistent with a Gerbode defect. So these are about as rare as hen's teeth outside of the congenital cardiology sphere, and when they do happen, they're almost always after a cardiac procedure or endocarditis. In fact, only 3 cases in the literature were found about these after blunt trauma, and all of those have been repaired surgically. But as you can imagine, our surgeons were not exactly queuing up to operate on a gentleman with no platelets and an unstable pelvis. And while a percutaneous approach has been described in the post-surgical and endocarditis spheres, it had never been done as far as we knew, and so we weren't sure if that was the same disease or not. But after extensive discussion, we decided that that was the best approach to take, and so here's some pictures of how we did it. So this is retrograde access going up through the femoral artery, looping back around the aortic arch, through the aortic valve and passing a little wire through the defect and out into the right heart under TOE and fluoroscopic guidance. We then inserted a snare up through the right femoral vein, caught the wire and pulled it out to make an arteriovenous loop, and that was used to railroad in the device, which when deployed you give it a good big tug to make sure you're in the right position and it's stable, and when you're happy with your position by TOE, you deploy the device. And things looked great after the initial procedure for about 8 days. And then the patient got really sick again. And you don't have to be a cardiologist to see what's not here. Where is the device gone? Well, it's in his pulmonary artery. So back came our friend the snare, and we managed to grab hold of it with a little bit of difficulty. And after a few goes of trying to get it out, we eventually were able to bring this towards a peripheral vein. It needed a little bit of shimmying to get it as distal as we could with some balloons, and then our vascular surgeons helped us out by vascular cut down. So we were back to square one. But thankfully, after 8 days of normal hemodynamics, this gentleman's liver and kidney function had improved to the point that actually he had platelets again. And the surgeons felt that it was probably reasonable to try a surgery. So he had an operation, and a very good one at that. And from there on in, he had quite a good outcome. He went on to have his pelvis fixed. And after a period of rehabilitation, he walked out of the hospital fully independent. So just some brief points of discussion. This is, as far as we know, the first reported percutaneous closure of a Gerbode defect caused by blunt trauma. And despite technical success measured by both real-time TOE as well as right heart catheterization, it didn't produce a robust result. And there's a few kind of hypotheses we have about that. I think that this shows how difficult it can be to find a very rare thing in amongst multiple distracting injuries and medical conditions. And really the crux of this case was actually when we just went back and looked at that echo I showed you and saw the abnormal swirling in the right atrium, which just didn't look like tricuspid regurgitation. So rather than just reading reports, making sure you go back and look at your raw diagnostic data is sometimes the key to these things. And with that, I'll thank you for listening and take any questions.
Well, if we were back to school, we'll probably go to the cath lab. Amazing pictures. Thank you very much. We have as a commentator here, when we don't know whom to ask, we ask Dr. Panju, and that applies here and it applies in Hamilton. Akbar.
Thank you very much. I'm no expert on this condition. I've seen many cardiac defects, but I haven't seen one with the MVA. I have, 3 little questions. First, why is it called Gerbode thing? Is it the patient who was Gerbode, or the Dr. Gerbode described it, or is it an adjective? That's question 1. Question 2, so the echo wasn't done when the patient first came in. And if it had been done, would you have diagnosed that defect in that tricuspid thing? And 3, what do you think is the mechanism? Is it just traction? Is it what, why does it happen? So those 3 points.
Sure. So firstly, Gerbode, I believe, was the surgeon who did a series repairing a few of these in congenital cases. I can't remember where he was from, but this was back, I think, in the 60s and 70s. The second question about the echo. So an echo was done initially in the initial hospital, which was a relatively small district hospital. And you would wonder why a major trauma was brought there in the first place. But it was done in the ICU as a portable scan. The patient had very difficult positioning, as you can imagine, with all these fractures going on. And the question asked at the time of the echo tech was, is there a pericardial effusion at that time? Which there wasn't. And I guess it kind of comes back to, the difference between a full study or a focus study, because this was a focus study and the echo tech I documented couldn't get great views. It was amazing looking back at this to see all the times we could have picked this up. And even looking at her pictures, she had a color box over the atrial septum, a color box over the ventricular septum, and that tiny gap that she didn't look at is exactly where the defect was. And again, I guess that goes back to looking at your raw data, because the report of that scan followed the patient to the other hospital where the images couldn't be viewed, and everyone kind of just took it as gospel. This was tricuspid regurgitation, pulmonary hypertension. It was only when we looked at it again that we realized, that was a good guess, but it was actually wrong. And then the final question, the mechanism. So as I mentioned, the vast majority of these are congenital, and usually it's after cardiac surgery or TAVIs. There's been a few cases of endocarditis. In this case, we were just thinking it was such a high velocity crash. It's just blunt force and I suppose the shear stress and the tearing force. With regard to the mechanism of why the procedure didn't produce a durable result, our best guess is that there was possibly ongoing necrosis. It was just after the 2-week mark, still in the period where you might see a VSD form after an MI, and possibly the anchoring tissue at the perimeter of the implants just started to fail and fall away, and then obviously it came out again.
Thank you. Another. Do I assume that pericardial effusion was independent on this defect, or they were connected somehow?
So at surgery, they noted that it looked like a traumatic pericarditis. So it's a sticky pericardium. I think it was incidental,
So
but it was
bad luck.
Yeah, it was just the trigger to go to the hospital where eventually it was sorted out.
Thank you. I have two questions. One question is regarding the initial pericardocentesis. I suggest, according to the echo pictures, that there was a complete removal of the effusion, and I would like to ask you what was the time during the, because if this was too quick, complete removal, it might worsen the right ventricular function. And the second question is regarding the procedure itself, the closure of the defect. A very difficult procedure. There are only few interventional cardiologists who are capable to manage this procedure, and there I didn't see that on the pictures. There is something which is called a Minnesota maneuver, which we control the stability of the occluder. And was this maneuver performed during the procedure or not? Because something what may cause the embolization is Davis undersizing, and this maneuver can control whether the position of the occluder is stable or not. Thank you.
Sure. So the initial drainage, that 1500 mils was over a 24-hour period. So there was an initial small amount taken, and then a drain was left in situ and was clamped and periodically opened. I'm not familiar with that specific maneuver, and obviously from time constraints couldn't put in all of the pictures. But we did initially try with a 14 millimeter device, and then that was upsized to 16 millimeters because we felt that just wasn't covering everything. And as to whether, I suppose, were we just technically unsuccessful? I think the first time, when your first thought when a procedure goes wrong is, did we just not do a very good job? But the fact that the right heart cath and the real-time 3D TOE were so pristine looking, and the fact that it was 8 days before it fell out, made us think that probably it wasn't a technical issue as much as I said, the ongoing necrosis of the tissue.
Okay, well, this is fairly sophisticated discussion. We probably will need to continue it together. Thank you very much for...